I would just like to say welcome Dr. Ian Day, who will be presenting for us today. My name is Bronwyn Walker. I'm the Stakeholder Relations and Policy Manager at MPS Medicine Wise. I'm filling in and helping out the lovely Anne-Marie today to support the Choosing Wisely team. So she's enjoying some well-deserved break, and then she'll be heading off on maternity leave. I'd just like to start by acknowledging the traditional custodians on the land on which we meet today and pay my respects to their leaders, past, present and emerging. I'm coming to you from Darkinjung country today on the central coast of New South Wales, and the rain is just about to start pouring down. What a wonderful number of people. We've got 35 participants on so far. We're excited to have Dr. Ian Day presenting on virtual medicine, emergency medicine. So thanks, Ian. Ian is an emergency physician and co-director at Fiona Stanley Hospital in Western Australia. He was previously the clinical commissioning lead for the Fiona Stanley Hospital and currently the clinical lead for the South Metropolitan Health Service Virtual Emergency Medicine Service. We're very excited to have him here today and present. And as I said, we want to keep this session fairly informal. So please feel free to answer and throw any questions into the chat. And I'll hand over to Ian. Thank you so much, Ian.
Hi, everybody. So as Bronwyn said, my name's Ian Day and I'm an ED physician in Perth and working at Fiona Stanley Hospital. Thank you for joining us on this webinar, and I'd like to pass on my thanks to Bronwyn and Anne-Marie for inviting me to speak. As Bronwyn said, Bronwyn's sort of going to watch the chat a bit while I present, and we'll endeavour to incorporate the questions into it as we go along, so it's sort of a little bit more interactive. I will try and leave some time at the end just for discussion and interaction as well. So I'm not aiming to use up the whole 30 minutes for the presentation, to leave a little bit of time for that. So I guess we're all familiar with really what's a national phenomena and a worldwide phenomena in our hospital systems, which is that we seem to have this overwhelming demand for hospital services, and particularly an overwhelming demand for emergency department services. And for reasons that I don't think we fully understand yet, that seems to have accelerated through the recent couple of years of our pandemic experience. And that's leading to long delays for patients. It's leading to lots of ambulance ramping, limited ability of ambulance to respond to the community. So it's certainly a serious problem. So, and the other part of, I guess, a concept that I'll sort of share with people is that this concept of sort of emergency department medical care versus access to other care. Some patients coming to the emergency department need the specialist input of emergency department staff, but some patients, for very valid reasons, are simply trying to access other care within our system and don't seem to have a direct way of doing that without coming through the emergency department. Now, that's not the fault of those patients necessarily. It reflects complexity navigating our system. It reflects perceptions of urgency, other service eligibility criteria where there might need to be some filtering, hours of service of operation of other services, and also financial disincentives for perhaps seeking alternatives to the emergency department. So for all those reasons, you have patients with significant problems, but they're trying to navigate to somewhere else and using the emergency department really as a portal of getting there. So what is virtual emergency medicine? So the concept came up because on a typically crowded day in our emergency department, we were looking at queues of ambulances and thinking, gee, if only we could have made some decisions or had some inputs at an earlier stage in this patient's journey, particularly prior to them maybe leaving their house or leaving the residential aged care, we could have in fact got the patient to where they needed to be in a lot more efficient manner. And it's about using the telemedicine to improve direct access to care by taking that emergency physician decision-making beyond the four walls of the emergency department. Particularly, the model was about access to care. So it wasn't something that we've done to try and block access to the emergency department. It's really to get the patient directly where they need to be without that inefficient loop for the patient coming through the emergency department. So what it does, it helps eliminate the bottleneck at the hospital front door. And we did it, it was an initiative of the emergency department team at Fiona Stanley in direct partnership and collaboration with St John Ambulance in WA. And as opposed to a lot of the other states in Australia where the ambulance service is run by the state, the ambulance service in Western Australia is a private provider, and there's a contract between them and the government. And that means that this required a little bit more sort of nuanced interaction, because we're in fact sort of liaising and developing a partnership with a private provider with their own sort of contractual complexities, and I'll talk a little bit more about that. So for those who are not familiar with Fiona Stanley Hospital and Emergency Department, the hospital was commissioned and opened in late 2014. The emergency department opened in 2015. It's the largest hospital in the state with a total of 783 beds and several state specialty centres. Fiona Stanley ED and Gold Coast are the two busiest in Australia. We're the other side of 110,000 presentations to the ED, with about 30,000 ambulance presentations and about 37,000 hospital admissions via the emergency department. So how does VEM work? VEM, Virtual Emergency Medicine. So what's on the screen in front of you is really the traditional model of ambulance interaction with the emergency department, where essentially they collect a patient and they come to the ED, and apart from the high priority cases where we're assembling a resus team prior to arrival, we don't know anything about it until they arrive. They arrive, they tell their story to triage, and we take it from there. So what is the VEM model? Well, the VEM model aims to insert the telemedicine team into that journey prior to the patient arriving at hospital, and in appropriate circumstances prior to the patient leaving where they are in the first place, so either their own home or residential aged care. And what it allows us to do is assess the patient in conjunction with the paramedic. So we've obviously got, we can talk to the patient, we can talk to the paramedic, we can talk to whoever else is on the scene, maybe relatives or residential aged care staff. We've got all of the monitoring equipment that the paramedics have, including the 12-lead ECGs, sugars, etc. And they help us with the physical assessment components. And we can start to make decisions. And so we can say that, okay, well, this is the problem that the patient has got. This is the kind of treatment or further assessment we need to institute. But we can potentially do that in a lot of ways that are more efficient and more specialised and more patient appropriate than coming to the emergency department. The system we created, we just created an in-house system because initially we knew that to get this up and running, we weren't in a position to sort of put our hand out for a large grant and do a lot of IT development. So we developed a system in-house, which will now be sort of scaled and developed and corporatized. But essentially it uses the iPad infrastructure of St John's. They've got an e-form, an e-interface on that form on their iPads. And then that, through a whole lot of underlying automation, creates a dashboard of patients and information, and also messages within MS Teams that help communication and help the sort of the mobility aspects, because you can utilize a lot of just smaller devices such as mobile phones. And then again, through the iPad interface, we use the iPad itself for the actual the telemedicine interface, so the video conferencing components. We implemented it in a phased fashion. In February, we came up with it all evolved quite quickly in that we came up with a concept in December 2020 and managed to pilot the first of the inbound ambulances to FSH in February 21. Through that early part of 21, we really just sort of honed the service, made sure everything was okay, made sure our sort of governance was all right, and then really started to ramp up mid-2021, where we expanded it to 7 days a week. In August 2021, we officially started the residential aged care in reach, which was really the concept that we'll start having patient encounters before an ambulance has left the scene, before any decisions have formally been made to transport that patient to a hospital. In December 2021, we started incorporating inbound ambulances to other South Metro hospitals. We've got Fiona Stanley as a large hospital in South Metro, and then we've got two smaller general hospitals, Rockingham and Peel Health Campus. So we started to incorporate those. And the phase 5, which we haven't done yet, but we're hoping to do later this year, is GP in reach, where the concept is that we can have a teleconsult with a patient that a GP is referring, again, and just streamline things when that patient comes to hospital, because the current phenomena is that some of those patients sort of start again, and that they arrive to the emergency department, tell their story, wait in the waiting room, and we sort of reinvent some things. Whereas really our goal would be for the patient to be coming for a specific purpose and utilise a specialist area of the hospital where appropriate. Some build themes that were important along the way. We knew it had to be a partnership with St John's Ambulance for this to really work in the concept that we were going forward with, and that partnership had to recognise that it wasn't a contractual partnership. It was actually a sort of built on a lot of goodwill and sort of gentlemen's agreements, knowing that if things work well, then hopefully they'll subsequently be incorporated into the contractual side of things. We wanted it to be about patient-centric models of care, and I'll talk a little bit more about this, but from the get-go, we wanted the win-win here to be that, yes, it'll hopefully reduce a bit of ED overcrowding and ambulance ramping, but that has to be by instituting better models of care and having patients directly access the right care, rather than anything that sort of just tries to reduce access to the ED for the patients without some better alternative. And it was about improving early access to the right care. Our whole theme was leveraging from and enabling existing services. The VEM service itself wasn't to be the definitive way of delivering the care. The VEM service was really to have patients access other services that are the right care, but patients, for some reason, don't end up directly there. So building on the existing. And engagement with general practice, residential aged care, and all those providers and consumers from the get-go, so that we could factor in all their requirements, factor in anxieties, build that into sort of the models that would work for all agencies. The diversion cascade we were looking at was that what we want to achieve where possible was complete hospital avoidance, i.e. care in the community, either care in a patient's own residence or care in the residential aged care facility. If we couldn't achieve that, then we would look at tertiary hospital avoidance by using specialised services at our secondary hospitals. And if we couldn't achieve that, then could we achieve streamlined pathways once the patient came to the FSH, but didn't have to come through the acute areas of ED, so that those resources were preserved for others. So far, activity and performance to date. So far, we've had, during the operational hours, we've processed just under 8,000 ambulances through the VEM unit. And that's achieved right from day one, the percentage of 27% diversions away from the acute streams of ED has been pretty consistent. And so from the time we had 100 patients through to the time we've now got 8,000 patients through, it's remarkable how that percentage hasn't really changed. Just visually, I don't think the detail matters, but visually you can just see all these other little coloured spots are all the other sort of pathways that the patients can now go down, instead of this blue pathway, which is really coming through the ED in a somewhat business as usual format, and just presented in a different way. There's some raw numbers of the patients coming through. Now, just to explain these, ESSUs, the Emergency Short Stay Unit, remained in community, self-explanatory, AECC, and ambulatory emergency care clinic, and I'll expand on these in subsequent slides. Just a comment that BAU, business as usual, what we have found is that even though that doesn't mean the patient's following an alternative pathway. That has reduced our times to triage, increased our turnaround times of the ambulance, because what it means is that a lot of ambulances are arriving and they are already triaged. So they're not, in fact, joining the queue for triage. And as a big ambulance site on a large day, we'll get up to 130 ambulances a day. You sometimes end up with queuing of the ambulances just to be triaged. So it's helped us manage that sort of front of house workflow. These graphs here, busy slide, so don't worry too much about the detail, but this really is about residential aged care. And what we found is that overall, we have that 27% diversion rate of patients. But in fact, for patients from residential aged care, it's 38%. So we can divert more patients if they reside in residential aged care. And that's really because we can take more services into the patient. And the patient's already got access to what you'd call basic nursing care, basic, somebody to help them move, shower, feed, etc. So we've got some more options. About 18% of our total caseload through VEM has been from residential aged care. And these graphs here, this just reflects the patients from residential aged care diversion versus the non-residential aged care. So the slice of the pie that we're diverting is larger. So, and this is quite significant because the big demand growth area for virtually every health sector in Australia, certainly most of the urban ones, is the over 65. So we know that an expanding sort of health burden or health workload, if you like, is going to come from the increasing aged and frail age. So we know that from a system demand management point of view, wherever you can change a model and deliver care in a better way for the frail aged, that's high yield for our system and our hospitals. Care in the community. So how are we actually doing that? I mentioned before, sort of leveraging off existing agencies. So general practice, residential care line, which is a service, state-run service that goes into the nursing homes. Choice, again, a big allied Jerry service, which was, the acronym is Choose Home over Inpatient Care Every Time, Silver Chain, Rehab in the Home, Complex Care Teams, MPACS, which was palliative care. These services all existed, so we didn't have to create these, but they were often underutilised, and we would often get the feedback from these services that, gee, we could have dealt with that patient rather than that patient coming to hospital, but they hadn't been referred to that patient prior to that being sent to hospital, sort of ball rolling. Care at secondary hospitals. So the picture in the back is Fremantle Hospital. So Fremantle Hospital was really used to be the sort of the southern, the South Metro tertiary hospital, but that was sort of wound down when Fiona Stanley was opened, and Fremantle is now sort of a specialist hospital. So it does a whole lot of elective surgery, big mental health space, but also focuses on general med and the frail age. And so what was created there by our geriatricians was an inpatient unit called the RATU, or Rapid Assessment and Treatment Unit, to focus specifically on the frail age. So it's really like an acute medical unit, but specifically for the frail aged patients, and also a large choice clinic there. So a big, like a day therapy, day clinic space with a lot of allied input and direct Jerry's access, where you could bring a patient to have that sort of lengthy assessments over a space of a day, and then either implement care back in the community or admit them to the RATU unit if they really need to stay in hospital. And so we can now send ambulances directly to Fremantle Hospital, despite the fact it's got no emergency department, because we can sort of pre-screen those patients as stable, and the ambulance simply takes them to the ward or takes them to the clinic. In terms of the tertiary hospital pathways, if the patients are coming to Fiona Stanley, we've got the emergency short stay unit, an ambulatory emergency care clinic, an ambulatory chest pain pathway, which is something quite new, and some other pathways, and I'll talk briefly about some of those. So the ambulatory emergency care clinic was kind of based on a concept that had been in existence in the NHS, where you could use this ambulatory care score, and if patients were if the score was high, then generally they could be assessed in the clinic and discharged. So our triage or our other staff can sort of pick these patients based on those scores and send them to the ambulatory clinic. And so really we're now just doing that pre-arrival at hospital via the VEM unit, and the ambulance just dropping the patient off directly in the clinic rather than having to do the initial processing via the ED. And what this allowed us to do, though, it dawned on us that we could perhaps come up with an ambulatory chest pain model. So for anybody online who works in an emergency department, you'll be familiar with the fact that chest pain is quite a common presentation. We tend to give it a high triage score, typically at ATS2, and they tend to go to the monitored area of the department, which is often the resus area. So chest pain becomes quite a high burden for the acute and resus areas of your ED. But the reality is that most of those patients, in fact, don't have anything acutely life-threatening. Some of our processes regards the chest pains are a little bit historical prior to the pre-hospital diagnosis of the ST elevation MIs and the pre-hospital ECGs and telemetry, but we haven't really changed our emergency department flows. So what we do now with these chest pains is have a chat with the patient in the back of the ambulance. We've obviously got their full suite of vitals. We've got direct access to their 12-lead ECG from the back of the ambulance, which transmits through into our VEM system. So in essence, you can basically do the assessment you would have done once they got to the emergency department, in that you've got a full history, full vital signs, 12-lead ECG. And that allows us to risk stratify the patients, and the low-risk patients can then go directly to our ambulatory clinic environment, because the vast majority of those patients are going to go home at some stage a bit later. They might need troponin examination and a few other things, but they'll almost certainly be discharged. And that's, again, helped sort of declutter the emergency department. And the importance of that flow is that those acute patients, chest pain patients flowing directly into resus can often trump the inflow of patients who've been sitting waiting in the waiting room for hours with their abdominal pain or some other problem. We also were able to streamline things for our proximal femoral fracture patients, the NOFIs. We're the largest NOF site in Australia, with about 650 NOFs a year presenting through the ED. And what we've been able to do now is have, because we're the surgical site for the South Metro, we've been able to sort of really create pre-hospital diversion to FSH and avoid a lot of secondary transfers of these patients, because we'll do the VEM assessment in the community and say, I know you're next to Peel Health Campus, but that's almost certainly a NOF, so come directly to Fiona Stanley, and it improves access for those patients. It also means that because the patients are triage, linked, clerked, everything available before they arrive, we've created a system where the paramedics can just literally come through the front door and continue to X-ray, and then they just bring the patient back from X-ray and drop them off. So what it means is it's true X-ray on arrival, and that just speeds up a whole lot of other hurdles for these patients, because that big fork in the road is actually seeing that fractured femur on the initial X-rays. One, I think, perhaps to me, the most important bit of what we've done, perhaps because it's just a little bit of a passion of mine, is supporting end-of-life care consistent with patient and family wishes, both in the residential aged care facilities and the community. I think we're in an age where lots of patients have expressed wishes about what they would like around the end of their life. That may be on basic goals of care form. It may be on legally binding advanced healthcare directives. But pretty much the community is in agreement that we should have access to this. We should have some control over what the end of our life looks like. And so those documents exist really commonly, but often the patient has a sudden change in their state. They're found they're not conscious, for example, and nobody there at the time is empowered to say to the patient or their relatives that this is the fork in the road you were talking about, and so would you like us to facilitate that sort of comfort-based care or end-of-life care consistent with those wishes? So too often a patient has to come to hospital to have that sort of discussion which they documented they kind of didn't want to do in the first place. They wanted to stay where they were. And so we've now been able to have those conversations both in residential aged care and the community and mobilise the palliative care supports where necessary. And that's been a really quite a satisfying thing that the families and loved ones have really welcomed, because that's what they actually wanted. The future. So we're looking at sort of metropolitan expansion in Perth at the moment, and how we set up a single sort of model across multiple HSPs, and just discussing those things. It will ultimately need a funding model. Virtual medicine, because of its relative newness, particularly emergency medicine, it doesn't actually have a funding model at the moment. The current activity-based funding model doesn't really support it. So that's got to be developed at some stage. We've got to work out how to share more information across providers. As I said, St John's is a private organisation, so being able to sort of share clinical information to streamline the IT and the communication, we're working on that. And I guess too, we've got to make sure that state contracts with things like the ambulance provider actually support the model we want, because if an agency's paid predominantly for transporting patients, then there's less incentive not to transport the patients and have seen consults and do otherwise. And so that's all of the things, little challenges that we're working on at the moment. Couple of quick acknowledgements before I throw open to questions. The ambulance service, obviously, because we couldn't have done this without a lot of goodwill from them. The team at FSHED and the innovation team at South Metro. And we've had a lot of really good input from our consumer reps and our GP liaison, which has sort of helped us too. So I'll stop talking there and endeavour to answer any questions that anybody's got.
Thank you, Ian. That was wonderful, and what a great model and solution to some of those bottleneck issues. I've got a question. Is this something that will be rolled out nationally at any stage, or there been discussions?
Yeah, look, so there is, because there was a whole lot of virtual models that cropped up and exploded sort of through the COVID period, we're now at the phase where we're all catching up a little bit and working out what everybody's done. A lot of the models are a fraction different, but the discussions at the moment are really collating what's been done, what are the commonalities, and how do we start to set common frameworks with things like quality control, KPIs, and those sort of things. So at least we've got some sort of common vision of it. So those discussions are occurring at the moment.
Wonderful. Thank you. Was there any other questions on the chat at all? Just checking it now. There doesn't seem to be. No, all good. I'll give everyone 10 more seconds if there's anything else. So there's just a question from Roy. So how is the current model resourced? That's the first question. So,
yeah, great question. So for the moment, we're just block funded. We negotiated just with the proposal a block of money to pay for that, with the ongoing discussions about how you would start developing an activity-based resourcing model. And who does the consults from Rachel. So the team is a triage nurse and an emergency physician. And so depending on the case, if the case is a relatively straightforward inbound hospital, the triage nurse may just sort that out. If there's anything more complex, then both the triage and the medical interaction are all done simultaneously in discussion with the paramedic, patient, family, whatever, depending on the construct. From Anne, will the future be a 24 service? I don't think we'll go 24/7, because I think the wee hours probably between 11 in the morning are probably fairly low yield, and we'd probably struggle to justify the funding of that. But we would like to go pretty much 15, 16 hours. And capture a lot more. At the moment, we've only got funding for one shift a day, so we do 10, but ultimately we'd like to do about 16 hours and then have a coordinator role that can disseminate some of the referrals the next day to the in-hours agencies that we liaise with.
Yeah, do the interstate ambulance service have the same capacity of pre-hospital assessment and comms with the hospitals?
So interstate, I know that there is some interactions. I don't fully understand all the models there yet because, as I said, we're just starting to all socialise the models that we created. I do know the model in Western Australia was a little bit unique in that it was aimed to be a fairly comprehensive assessment on scene and free up other pathways, so it was a little bit unique. There was a model about how we're recording it in ED, so the patients go into EDIS. I think I saw a comment there about EDIS. So we just record them in EDIS and they're recorded as virtual, so we can identify which consults were real and which consults were virtual only in terms of working on the subsequent funding model. Do we have any staff working remotely or interstate? No, except for one instance where one of our consultants was stuck in London during the COVID thing and wanted some work to do, so did some. But basically, it's our local consultants because a lot of the pathways have some local nuances, so a little bit of local knowledge helps a lot. Quality control. So we're having regular clinical review meetings where one, we discuss any problems that were identified. Two, we discuss all the patients where we initiated end-of-life issues. And three, just look at the interactions with our other general hospitals and make sure that the right patients are going to the right locations. So we have 2 monthly, M&M or clinical review meetings to look at the cases. If directed, there's a case there, if directed straight to ESSU, who would be responsible for the care, ED staff or treatment users? So when they go straight to ESSU, they are ED patients, and the short stay units treatment. So the consultant allocated to short stay for the day and the junior staff there. So they're still under ED governance, 100%. Do you ever want to divert away from ED? Yep. So in terms of diverting, so from James, diverting to rapid access clinics and subspecialties. Yes, where the patient has a known relationship with a subspecialty, we will do that. It also allows us to do the stability assessments on some of the planned transfers instead of bringing them through ED. Patients with head and neck problems where somebody might have had to ascertain that their airway is still stable, GI bleeds, are they hemodynamically stable? Now we can do those assessments 15, 20 minutes out from hospital, and where there is a proper bed for those patients, they can go direct to that bed having had that stability assessment rather than sort of be dropped off in ED and then wait for porters, et cetera, et cetera. So from Andrew, you mentioned incoming ambulance might be sorted by the triage nurse. Does every incoming ambulance consult? No, not every ambulance does. The high priority P1s don't, and we don't do it for less than 16-year-olds because we don't have a high volume of paediatric ambulance. Most of those kids are sick anyway, and we don't have the alternative pathways. So we encourage our paramedic crews to use VEM for everything that's not high priority or less than 16. But some still arrive, and some of the paramedics who are new to the area forget to activate the system because it's not mandatory yet from St John's point of view.
Just one question from, I think, where was it? It was just from Natalie. Thank you for the presentation. How might this model be applied for rural/regional and inter-hospital transfers in WA?
So that's a really good question. I think that it could perhaps have even more value in rural WA as a way of supporting volunteer crews, because we have, we have far less paramedics in the country. And I also think those complex prioritisation decisions about moving country patients and where you have to supporting them where they are for a little time while they're waiting for transfer because of pressures on RFDS. So I think it's a model that ultimately I would love to see implemented in the country so that we could really have that emergency physician presence and assistance with less resourced rural environments.
And we've just got one last question. I'm just conscious of the time, and I also wanted to hand over to Robin Lidner, our strategic manager at MPS Medicine Wise, just to give us an update about, obviously, the news that people would have heard about MPS Medicine Wise. So we've just got one last question. What worked well to change paramedic behaviour processes in calling you rather than transporting directly to the hospital?
Yeah, look, that's a really good question because, how we engage with them. I think what worked was that, one, the paramedics were motivated to help change a system that they saw as becoming increasingly dysfunctional and failing. And they themselves were aware that they're bringing patients to hospital who would be better served by some other area or some other specialty. So they knew that. But also the way we partnered with them and the way that the paramedic is, I guess, part of your clinical eyes and ears. It was a relationship that was quite professionally respectful, and it was really a trusted referrer kind of basis because, for us to make those decisions, up to and including supporting end-of-life care, you have to have a fair bit of trust in the people and the clinical assessment that are on scene. So I think it demonstrated a level of respect for what the paramedics do, such that it helped that good relationship evolve.
Thank you so much, Ian, and thank you so much to everyone for your questions. What a wonderful model, and we hope to see it's rolled out nationally. Absolutely. I'm going to hand over to Robin Lidner from MPS Medicine Wise, and thanks, Robin, for providing us a bit of an update about, obviously, the news about MPS Medicine Wise, what's happening with Choosing Wisely, and I suppose just, next steps and keeping us informed.
And I'll just say before I go, look, I really appreciate everybody taking the time to listen to the presentation. Thank you again to the Choosing Wisely team for inviting me. I'll send my email to Bronwyn, who, are you able to distribute that to the group if anybody's got any further questions? Right, I'll do that after the presentation.
Yeah. Thank you, Ian. Thanks again. That was wonderful.
Thank you, everybody.
Thank you, Ian. And I think it was that presentation was just a great example about why I think Choosing Wisely is such an important initiative, because it creates opportunities like this for people to come and share great work that they're doing around trying to improve efficiency in the health system and reduce low-value care.
So thanks, everyone. Appreciate we're at time, but many of you will have heard that there was a budget announcement back in March that MPS Medicine Wise would no longer receive uncontested funding to deliver programs around quality use of medicines, and that includes the work that we do in facilitating Choosing Wisely. We fought hard to get that decision reviewed, and Labor committed to a review, and when they came into power, they undertook a review, but unfortunately, the outcome of that review has not meant any change in that decision. And so in the last fortnight, our board has had to make the difficult decision to actually close the business. And so we will be closing on the 31st of on or around the 31st of December this year. Part of the decision budget announcement is that a number of our functions will be either going out to contestable funding, or they will be transitioning to the Australian Commission on Safety and Quality in Healthcare. And we are currently in discussions with both the Department of Health and the Commission to understand what functions may be transitioning either to the Commission or to a contestable model or to another party. But there's a lot of information we need to work through in that process. Unfortunately, at this point, we don't have clear visibility around Choosing Wisely. We are obviously keen to get clarity on that as soon as possible, and we will communicate that with members and supporters as soon as we are able. So, but just wanted to give you an opportunity to let you know that that's where we're up to. If there's silence from us, it's not through lack of wanting to keep you informed. It's just that we don't have any more information to share with you at this point in time. But we would really hope that there's a life for Choosing Wisely out post MPS Medicine Wise in another home, and would just encourage you, if you've got particular questions about this decision, to contact us at the Choosing Wisely inbox email address if you have that. And I'm also happy to answer any questions offline or now if people have them.
Thank you very much, Robin.
So I'm sorry to finish after such a fabulous presentation on such a low note.
No, it's all good. It's very important information. We do want to know what's happening. So, yeah.
But in the meantime, I would suggest people are asking, should you continue with your projects? And I would say absolutely. I mean, organisations signed up to Choosing Wisely because they believe in the principles and values of the initiative, and I would strongly encourage you to continue, working on those programs within your organisations.
Thank you, Robin, for the update. Thank you, Ian, for that wonderful presentation. Thanks to everyone for joining us. I hope you enjoyed it. I'm sure there's some more questions. So as I said, Ian can share his email address and I can share that with you as the group, and please send them through. Have a good afternoon, everybody, and speak to you very soon. Thanks again. Bye.